Hello, listeners, and whoever is watching. Good morning, good afternoon, good evening, depending on where you are. We are excited to bring back the fertility awareness webinars in partnership with Fertility Point Kenya and Moms Cover. We are here to enlighten and share candid conversations around things that people don't usually love to talk about in public, and that is infertility. Today, in particular, we shall be looking at PCOS, which is polycystic ovarian syndrome. And together with me, let's welcome Dr. Ayale to take us through the details of what PCOS is. Dr. Ayale, over to you.
Thank you, Judy. And so I appreciate all the team for having me for this discussion. I'm Dr. Ayalew. I am IVF consultant as well. I am a reproductive endocrinology and infertility subspecialist. And currently I'm working at Fertility Point Kisumu as in United Mall as a clinical director. I think shall I continue to the slides? Okay. So, welcome all the participants, my guests, wherever you are. So, I started my presentation. Today's topic of discussion is about polycystic ovarian syndrome. It is a major public health problem, only female issue. It is a public health problem worldwide. So we should have some understanding on this line. So, as overview about this presentation, we are going to discuss about the manifestations, the diagnostic criteria, the concepts, complication, whether it is psychological, physical, as well as reproductive issues that are associated with polycystic ovarian syndrome. So, what's polycystic ovarian syndrome? Polycystic ovarian syndrome is a heterogeneous disorder that affects ovarian function, where basically it arises from what? The genetic makeup of that individual. And it has not only effect on ovarian function, but it has also other metabolic activities that affects the body by producing excessive amount of those basic hormones, specifically androgen hormones. So for diagnostic purpose, we use the Rotterdam 2003 Rotterdam criteria. And based on this criteria that I'm going to deal next, we can label a person, or you can label any woman whether she's having this disorder or not. So it is characterized by mainly some sort of menstrual irregularity, fertility issues, and phenotypic manifestations like about hair, acne, and also some sort of male type baldness. So I bring this picture to outline and to understand how these hormonal metabolism are working. So hormonal metabolism works normally starting from secondary sexual characteristics, most of the time starting from by the age of 12, 13. And basically this is ignited by first the production of GnRH, gonadotropin releasing hormone, from the hypothalamus that directly stimulates the pituitary gland to produce follicular stimulating hormone or FSH and LH, luteinizing hormone that directly act on what? Ovary or oocytes, egg maturation and follicles. So the ovary produces estrogen and progesterone. This is what we know normally. Okay, what should happen normally. But here, this estrogen production and progesterone production at cellular level is handled by what? The follicle. So these follicles are network of cells which are called theca cells and granulosa cells that surrounds the oocyte or the egg. So in the TK cells, the first screen that you see, from cholesterol, pregnenolone, and other cascade of metabolites that finally end up in the production of testosterone or androstenedione, which is what? Androgen hormone. This happens in the TK cells. And this androgen hormone transferred to what? To the nearby glandular cells, and by the so-called process of aromatization, this androgen hormone will be changed to what? Estrogen hormone. This is what happens normally. Okay, so in polycystic ovarian syndrome, what is going to disrupt is this two-cell theory. That means producing androgen hormone to the certain level in the TK cells and producing continuous production of estrogen hormone, especially during ovulation, in the glandular cell will be disrupted. Okay, so for this, as we have said, we use criteria, and this criteria is called Rotterdam criteria after the meeting about this polycystic ovarian syndrome. Previously, it was called Stein-Leventhal syndrome, but when it is boundary becomes wider and it touches every part of the body, so we constantly use the term polycystic ovarian syndrome. So for the diagnostic purpose, we use three criteria. From three criteria, if the candidate or if she fulfills two criteria, she is labeled as having what? Polycystic ovarian syndrome. The first criteria is anovulation or oligoovulation. This means when the ovulation is lasts every 40 days or more than that, delay of 40 days or more than that, or when there is only 9 menstrual cycle or less than 9 menstrual cycle per year, we call it oligoovulation or 9 ovulation per year. And the other is ovary itself, polycystic ovaries. Okay, when the ovary is having lots of follicles, more than 12 per ovary, and if we have such type of follicles in both ovaries, so this is one criteria. And the other is the ovarian volume less than 10 millimeter or less than 10 milliliter or centimeter square. So this is also one criteria. And the third criteria is hyperandrogenism. Any evidence of phenotypic or internal findings that suggest for hyperandrogenism. This includes mainly dermatologic finding like acne, male type baldness, or hirsutism. That means where hair is expected to grow in male pattern. If hair grow in female, we call it hirsutism. And if such things happen, so we call it what? One diagnostic criteria. So anovulation or oligoovulation, polycystic ovaries, which is diagnosed by ultrasound, and hyperandrogenism. From these three criteria, if she is having two criteria, if she fulfills two criteria, then we label that client, that customer or candidate as polycystic ovaries. There are other hyperandrogen findings where we call them virilization or other based on the differential diagnosis, but we don't discuss about that. We only discuss about polycystic ovarian syndrome. So this picture shows when the ovaries with polycystic. Okay, so these cystic structures are follicles. Okay, but they are not continuing their growth. They are always at antral stage. That means antral follicle. That means their size is less than 10 millimeter. They cannot go beyond 10 millimeter. So in both ovaries, having network of chiral shape network of these follicles on both ovaries, then this is one criteria to label them as polycystic ovarian syndrome. The other is the table that you are having is hormonal conditions that you are expected in polycystic ovarian syndrome. For example, FSH to LH ratio will be low because those follicles are not ovulating. So the FSH level will be moderate, but LH level will be high. So because of this, LH to FSH level will be low, or if it is less than 0.5, then it is highly suggestive of PCOS. Or LH to FSH ratio less above 2 times, it is suggestive of PCOS. That means the reverse. The others are findings that are suggestive of what? Other differential diagnoses. For example, DHEAS, dihydroepiandrosterone sulfate, is a hormone produced by adrenal gland. It has typical finding like that of what? PCOS. But if this hormone is elevated, so we have to suspect what? Adrenal tumor, adrenal mass, or hyper adrenal pathologies. Yes, ultrasound should be done, including the adrenal gland, and also to see the nature of the ovaries is one important diagnosis. And insulin level, we can't actually measure insulin level. What we can do is we can measure glucose level. So when the glucose level is above some thresholds, like above 110 milligram per deciliter before meal, so it is called glucose intolerance. So it is an indirect evidence of what? Insulin resistance. So insulin resistance is the main cause for what? All metabolic disruption in the body. So insulin level will be elevated when androgen level or testosterone level is elevated. So this testosterone level is continuously produced by what? Those antral follicles from what? From the ovary, specifically from the theca cells of each follicle. So PCOS can be classified into 4 groups, and it is basically from the diagnostic criteria. As we have said, anovulation, polycystic ovaries, hyperandrogenism are the main 3 criteria. But there are what? Non-criteria, other finding. For example, obesity or other finding like uterine atrophy or hypertrophied uterus or hyperandrogenism evidences like balding. These are not criteria. And other criteria or other findings like obesity, diabetes. These are not criteria, but findings that can suggest for PCOS. So phenotypic A or the classic one is here to be hyperandrogenism, ovulatory dysfunction, polycystic ovary. That means all the 3 criteria. If the client fulfill all the 3 criteria, we call her phenotype A. The one which is B is non-PCOS, non-PCO. That means the ovarian finding is not there, no polycystic ovary. But the client has what? Hyperandrogenism and ovulatory dysfunction. That means oligomenorrhea, menses coming delaying beyond 35 days, or menses per year only 9 times or less than 9 times. So if there is no ovarian finding, then they are phenotype B. The phenotype C is ovulatory PCOS. Here the abnormality is what? Only ovulatory issues. We do have polycystic ovaries. We do have suggestive of what? Hyperandrogenism, but there is no what? Ovulation. Or there is what? Anovulation. Anovulation. So anovulation doesn't mean amenorrhea, okay? Most of the time they can go together, but it doesn't mean always amenorrhea is anovulation. A woman can have menses, regular menses, but no ovulation. A woman can have abnormal menses, but with what? With normal ovulation. So the phenotype D is non-hyperandrogenic PCOS. In this case, there is no evidence of what? Hyperandrogenism. abnormal hair growth like mustache or beard or hirsutism, that means hair on the chest, back, uh, or on the lower leg, thigh. There is no evidence that they do have what? Polycystic ovaries and ovulatory dysfunction. So this is based on these three criteria that we are using one from the other, that we want to differentiate each. So what are the manifestations of PCOS, polycystic ovarian syndrome? The first is menstrual irregularity. This is the most common manifestation. They can have oligomenorrhea, that means menses delaying more than 35 days, or they can have what? Amenorrhea, they may not have menses at all, while they are what? Adults, or while they are having what? Passing the primary sexual, the secondary sexual characteristic age, usually after the age of 14. Hyperandrogenetic features like hirsutism, acne, or alopecia, specifically androgenic alopecia, that means balding. Insulin resistance, obesity, acanthosis nigricans. By the way, acanthosis nigricans is the most important finding in those with hyperglycemia or in those with secondary diabetes. Obesity, when the body mass index is above 25 kilogram per meter square. Especially if it is above 30, it is strong evidence of obesity that can be associated with PCOS. These acanthosis nigricans are some black fluffy structures which are found on the body folding areas like around the pit or around the groin or around the neck. So they are suggestive of what? Hyperglycemia and indirectly hyperinsulinemia. Reproductive issues like infertility, recurrent abortion or miscarriage, or at all if there is no ovulation, or if there is no what? Evidence of progesterone production. So this can be manifestation for PCOS. Our differential diagnosis, there are common as well as very rare differential diagnosis. That means manifestations that look like PCOS but not PCOS. From all type of differential diagnosis, the most common is the PCOS itself, followed by what? Congenital adrenal hyperplasia. This is some sort of chromosomal abnormality that affects what? Production of this hormone from the adrenal gland. I will not go deeper because they are somewhat deep clinical. So congenital adrenal hyperplasia, Cushing syndrome that affects cortisol production, hyperprolactinemia, where the prolactin level by the pituitary gland is over, and it mimics that of PCOS, especially because of irregularity of menstruation. And it also suppresses FSH production. So FSH to LH ratio may be low. So hyperprolactinemia may look like, but what differentiates from PCOS is there is milk production from the breast without being pregnant. I can't say milk. It is galactorrhea, where there is no what? Fat bodies in that fluid. Both hyperthyroidism as well as hypothyroidism look like what? PCOS, because of their fertility issue and disrupting the menstrual cycle. There are also other criteria like androgen producing tumors from the ovary itself or from the adrenal gland, hypothalamic amenorrhea. Is it basically because of some sort of physical activities, stress, excessive sporting, where the patient can end up in amenorrhea, and obesity-related issues like insulin resistance, and also sometimes you can have what? Hirsutism without any other causes. So PCOS is a diversified metabolic issue that affects physical nature, fertility, and also even our capacity how to do things, like by affecting our metabolism, that end up in diabetes, hypertension, and obesity. So the first complication is because of anovulation. A woman, whether she is in need of pregnancy or not, she wants to have normal menstruation. This normal menstruation is highly controlled by what? Normal ovulation. So if there is no ovulation, so the menstrual cycle is highly likely to be disrupted. So infertility, which is followed by anovulation, is one complication of uh, PCOS. Metabolic disorders like diabetes, hypertension, dyslipidemia, obesity, this metabolic syndrome. One of the major causes of metabolic syndrome in women is PCOS. Especially in Africa, it's becoming quite common. Some people say it's because of the days, these corn-based days, increasing unnecessary fat accumulation. But still, metabolic syndrome in women while they are in 20s or in early 30s is becoming quite common. So I think something should be done on that line, because it's not only affects their day-to-day activities, it's not only affecting their fertility issues, but it's affecting their health as a whole. So PCOS also increases the risk of what? Endometrial cancer. Not only endometrial cancer, but also endometrial hyperplasia. These are two related issues. If you don't treat the endometrial hyperplasia early, then you end up in what? Endometrial cancer. How? Because PCOS continuously induces the production of estrogen. From where? From the ovaries. So this estrogen directly acts on endometrium. That means the uterus. So the primary target of estrogen is the endometrium. So continuous endometrial hyperproliferation, endometrial growth. That finally at one time end up in what? Endometrial cancer. So the other complication from PCOS is psychological effects that I am going to discuss next. So this picture shows how these important body structures like the pancreas, liver, ovary, brain, fat, how they are interacting and how they are being affected by PCOS. When I say psychological well-being being affected by PCOS, I'm saying these clients, our sisters, are having issues with depression, anxiety, disordered eating, low self-esteem, body image distress, because they are quite obese, central obesity, so their body image will be somewhat disrupted, reducing quality of life, the clothes that they wear. When they want to have hygiene, they can't, because their body habitus is quite difficult. Okay, so it has strong mental based complication. Dermatology, as we have seen, acne, androgenic alopecia, hirsutism is there. Reproductive issue, as we have discussed, hyperandrogenism because of hyperinsulinemia, oligomenorrhea, infertility, and even these polycystitis may end up in one day, may end up in what? Ovarian torsion, by the way. So acute autoimmune, emergency surgery can be there as a complication. So this picture, we can see how PCOS can end up in hirsutism, beard growth in women while they are in teens or 20s. And the second picture, acne around the chest, face, on the back, upper back. When there is acne, so this client should be considered. I am not saying that all women with acne are having PCOS, but it is high likely to be what? PCOS, especially in black race. Otherwise, the most common cause of acne is stress associated and some metabolic issues. Here in this picture, you can see PCOS-induced androgenic alopecia. Is the first picture. So it's also very common, by the way, whether it is in black or white or even in Asia, it is common, androgenic alopecia. And the other cause that end up in this alopecia is implants, these progesterone-based implants, also increase the risk of alopecia in female. On the second picture, you can see mustache, hair growth, which look like male, and again because of PCOS induced. How? Because these are androgen-driven phenotypic changes. From where the androgen is coming? From the ovary. Because the source of androgen is cholesterol, and the cholesterol is the one which is metabolized by the TK cells in the ovary that finally produce what? 50% testosterone, 50% androstenedione, which are both androgen hormone. So, for those with PCOS, there are some basic tests. Some are to confirm the diagnosis. Some are to differentiate other possible differential diagnoses, other possible clinical findings. So, we need to do LH hormone, FSH hormone, and TSH hormone because hyper as well as hypothyroidism are both risk factor. And prolactin because hyperprolactinemia is a risk factor. DHEAS, dihydroepiandrosterone sulfate, which is a hormone produced by what? Adrenal tumor from adrenal gland is a possibility, so we have to screen. Fasting glucose, lipid profile, HDL, LDL, VLDL, they are also important. Ultrasound to see the nature of the ovaries. Okay. By ultrasound, specifically transvaginal ultrasound, you will never forget once you see ovary which look like what? PCOS. So immediately you can know that this is PCOS. And also there are other metabolic disorders to differentiate one from PCOS by doing some blood tests like 17-hydroxyprogesterone. Okay. So let me come to the point and the treatment part. So when we are treating PCOS, we don't treat PCOS itself. Why? Because it is multifactorial. It has genetic, age, environmental issues. So we treat it is manifestation. We can't treat PCOS from its root. We can't. Okay? But we treat its manifestation. And we treat the concern of that woman. For example, if the PCOS end up in weight gain and excessive obesity, then we have to deal with that. How? Diet and exercise. If PCOS end up in hyperandrogenic effect like hirsutism, then we have to deal with it. Okay? Hirsutism treated by medical as well as some procedural like waxing, waning, and flicking technique or even electrophoresis. But to prevent reappearance, we have to use what? Medications like OCTs as well as spironolactone, which is antihypertensive but will metabolize the serum level of androgen hormone, so that reappearance of this hair will decrease. But to have this effect, the woman should take this medication for at least 6 months. So for those with ovulation issues, pregnancy issues, then we have to treat them accordingly. If the issue is only ovulation, we have to provide them what? Ovulation inducing medication. This can be letrozole, this can be clomiphene, it can be also injectables like gonadotropins, FSH based or FSH plus LH based gonadotropins to induce ovulation. Sometimes PCOS may be resistant for follicular growth. So in such cases, it is better to use what? These injectables. injectives. And the other is the patient end up in diabetes or insulin resistance, then we have to deal with it. Basically, exercise is important, and diet control is also important. And on top of this, we have to provide them medication like metformin. By the way, metformin helps not only for diabetes, but also for uh, ovulation induction. So, this is a picture showing atrophied endometrium and sometimes atrophied vagina, even though the vagina doesn't look like that, where we can find from what? From PCOS, because PCOS causes endometrial atrophy, where the woman may end up in what? Amenorrhea or oligomenorrhea. Even it can cause what? Vaginal atrophy. So it can have a diversified manifestation. It can also cause what? Endometrial hyperplasia. Okay, both things are there. So this is a dietary treatment for those with obesity and also ovulation issues, where it is causes PCOS based. So basically, these are what keto diet foods. Okay, you can have peanuts, fish, avocado, and eggs, and some green vegetables. Okay, so taking these diets regularly in moderate amount will change the energy source from glucose to ketone bodies. So the patient has higher chance of losing weight or fertility will come back. Okay, so will be resolved. So if the patient can have weight loss as high as 10% of his weight, so this is considered as by itself a treatment. So these people can have what? Regular menstruation and regular ovulation. So for weight loss, there is no other magic except diet and exercise. Okay, dietary control and exercise is basic. For those sometimes which is PCOS resistant for medication like chlorpheniramine or letrozole, we can go for what? IVF. We do have multiple cases where PCOS is resistant for medication. So we have to what? We have to shift for IVF. Then we do have also lots of clients who conceive after IVF. So PCOS is a lifetime metabolic disorder. The client should know this at the time of diagnosis. And it affects psychological, metabolic, as well as reproductive issues, health issues. So she should have first some sort of well understood way of life that can help her to achieve its goal. So the earlier the diagnosis, the best, because she will choose what to do at what time with regard to diet, exercise, and life achievement, and for fertility, early treatment rather than getting delayed. So treatment should be individualized based on what symptom and goals. That's what I have said. Okay, like malaria or like pneumonia, we can't treat PCOS from its root, but we treat what it is manifestations and the individual interest. Okay, so sometimes we need what multidisciplinary approach. Here, psychologists may be needed, nutritionists may be needed, and advisors about ways, uh, sportsmen that can coach how to lose weight by gymnastic may be needed. Okay, so sometimes internists, if the patient end up in metabolic syndrome like diabetes, hypertension, obesity, internist also is needed, and health issues It can be dealt based on. But the problem is, most of the time when the clients are having PCOS, they don't come to clinical findings or clinical activities. Most of the time, if you see a client with PCOS, specifically with hirsutism, like hair growth on the arm or forearm or chest or face, they prefer to go for what? Beauty salon. They don't come to us. So this causes some delay of diagnosis. And when the metabolic disorder is going on, there will be what? Difficulty to reverse it back to achieve the goal of the client. So we should have what? Some sort of public awareness by any outlet, media or whatever outlet, whether it's mainstream media, social media, to have an understanding for young women and all women to have early diagnosis and approach. Okay? Okay. So I thank you all my audience. And if you have any questions, concerns, ideas, I am here. I'm here to respond. You are welcome.
Okay. So I was saying, Doctor, thank you so much for that brilliant presentation. I am sure that whoever will listen will be touched in a way, and they'll figure out why their bodies were acting a certain way, the irregular periods, the weight gain, the weight loss, the growing of the beards. Those are things that some people underlook, and with this kind of enlightenment, I believe that they'll understand why their bodies are reacting a certain way, and they'll seek the support that they need.
Yeah.
So, to ask a few questions, I know that many of the questions you have already addressed, especially the symptoms. I don't know if I should repeat them, but I'll start with the ones that I feel you've not hinted on. Someone asked that, can a woman conceive when they have PCOS?
Okay. Thank you for the question. Uh, yeah. A woman with PCOS, she can conceive. The point is, we have to diagnose whether she is ovulatory or anovulatory, whether she is having ovulation or not ovulation. If she is not having ovulation, then we have to support her with ovulation inducing medication on top of what? Lifestyle modification, like weight loss, metformin, and avoiding stress. These are good. And also some diets, even in some areas, there are PCOS diet. So with that, she will be to the track back to ovulatory cycle. So as far as she is ovulating, she has a chance of what? Conceiving. But even with that intervention, if she failed to conceive, then we have to change our approach of management. Like we have to use more stronger ovulation induction or ovarian stimulation methods. So the question, in short, is whether she can conceive or not. Yes, she can conceive by what I have mentioned before.
Okay, thank you so much. The other question is, are there any foods in particular manage that condition? And
Judy,
is there any, yes, please, asking. Someone sent in a question and they want to find out, are there any foods that they can eat to manage PCOS? Or is there a cure for PCOS?
okay, this is also a very nice question. Yeah, there are foods that are recommended for those who are having PCOS. The most important point is preventing hyperinsulinism. Okay, how do you prevent hyperinsulinism? By suppressing serum or body glucose level. When the body glucose level is low, the insulin also follows the glucose and it becomes low. So in such cases, you'll control the manifestation of PCOS. So do you have diet? Yes. Which diet? Where the diet is less glucose source diet. All foods that are not white are good. This what I'm saying is rice or red bread or this spaghetti or this corn-based food, uh, whatever type, uh, they are high likely to increase serum glucose level. When the glucose level is high, insulin level also becomes high. So the manifestation and the complication of uh, glucose will be also high. So on the contrary, we do have what this keto diet. Keto diets are they primarily provide uh, ketone bodies, but not glucose. So the body prefer or metabolize the ketone bodies as energy source than the glucose. So there are diets where most of the time we call them ketone diet. Uh, as I have mentioned before, actually these are not lots of food items. They are few like fish, eggs, uh, peanuts, or butter of peanuts or avocado and green vegetables. Okay, these are the source where we call them keto diets. Can we treat PCOS as a whole? We can't treat because it's genetic. It has strong genetic exposure. The source is genetics that is supplemented with environmental and metabolic issues. So we can't treat because, but we treat what? It is manifestation, symptoms, and uh, the concern of the client for the PCOS. Okay? If you want to conceive, we treat her on the line of pregnancy. If you want to have a treatment for like alopecia, then there are lots of dermatologic issues where she has to talk to dermatologist. And if she has hair growth around the face, that means hirsutism. It should be dealt by dermatologist again. If it is metabolic disorder like diabetes, hypertension, obesity, so the internist. Huh? So that's why because his label does multidisciplinary disorder. So if there is menstrual irregularity, or if there is pelvic mass, or if there is infertility issues, anovulation, oligovulation, then IVF gynecologist is the one who is going to deal with this issue. Otherwise, even after menopause, the metabolic disorder of PCOS will continue. Okay.
Okay, I love that you've hinted on the question that I actually want to ask. Someone sent in a question and they're asking, can you explain the relationship between PCOS, insulin resistance, and fertility? Where is the
Okay.
intersection?
Okay. So the intersection lies androgen production. So the androgen production from the ovary is the central point that affects insulin production as well as fertility issues. So the androgen production, as I have said on my slides, from the theca cells of that follicle, continuously produce large amount of androgen from that all cystic follicles. So when the androgen production is high, at the same time the insulin production also follows that and it becomes high. And when the insulin production becomes high, it suppresses production of FSH hormone and LH hormone. So this both FSH hormone is very important for follicular growth. Okay, so the follicular growth will be poorer. So because of this androgen production, insulin level will be high, hyperinsulinemia, where we most of the time find in those with type 2 diabetes, and this insulin level also triggers suppression of what? Both FSH hormone and LH hormone, where follicular growth will be poor. If there is no follicular growth, there is no what? There is no ovulation. If there is no ovulation, then finally, no pregnancy. Finally, we have to label that client as subfertile or infertile.
Amazing, amazing. It's interesting how you keep hinting on the questions that I'm yet to ask. So someone sent in a question and said that they were told that they have multiple eggs in their ovaries, but these eggs are not of good quality and they don't grow to maturity. And also they bleed, but they do not ovulate. So it's confusing for her. She's wondering, how is it possible that I can have a period and I'm not ovulating? Can
Mhm.
you shed some light on that?
Okay, what we have to understand is in PCOS there are lots of follicles which are antral follicular stage, but the quality is also not good. The quality of eggs in PCOS is not good. One thing, and the other is even though there is a PCOS, even though there is no ovulation, there can be what menstruation. As I have tried to mention earlier, menstruation is controlled by lots of structures. Uh, it, the hypothalamus, the pituitary gland, the ovary, the endometrium, the uterus itself, all of them participate in controlling menstruation. So having regular menses is a network of at least four organs. At least four organs. The hypothalamus, the pituitary gland, the ovary, and the uterus, the endometrium itself. Okay? So from these structures, one structure which is not most of the time mentioned is body fat. Okay, body fat is the main source of estrogen hormone, even sometimes higher than what ovary produce. So this estrogen in the body fat is produced from what? From androgen hormone, androgen hormone by the process of aromatization by addition of aromatic ring. So body fat produce estrogen. Okay, that's why most of the time you see breast growth in obese male. Okay, in obese male, if you see their breast look like female, it is not because of the obesity. It's because of what? The estrogen hormone produced from the fat tissues. Okay, so they trigger the growth of male breast. So even though there is no ovulation, the estrogen, not only from the ovary but also from the fat tissue, uh, may control the endometrial activity, the uterine activity, and she can have menstruation. It can be normal, it can be somewhat abnormal, but menstruation can be there, even though there is no ovulation. Yeah. Judy, back to you.
Thank you for that elaborate explanation. I think I lost you for a second there, but yes, we were able to capture the explanation very, very vividly. And I know that whoever asked that question has been answered.
Mm.
The other thing that someone was asking is that they've grown hair here and then other parts of their bodies that they are not comfortable sharing publicly and they feel it is odd, and yet they have had children. So they are wondering, is it that they have PCOS and they didn't know? Do they need to worry about that?
Yeah.
Yes.
On the classification of the PCOS, if you see that slides, the PCOS classification phenotype A, B, C, D. From that three major manifestations, that means polycystic ovary, hyperandrogenism, and uh, the third uh, the third manifestation, polycystic ovary, hyperandrogenism, and oligoovulation. From these three, if one is absent, it can be A. If the other is absent, it can be B. If the third is absent, it can be C. Okay. So a patient or a client can have normal ovarian function, normal this menstrual function, but they can have what? They can have this hyperandrogenic activity. That means hirsutism, hair growth. Okay, so
Mm.
it's not abnormal having normal menstruation cycle, normal pregnancy, and even having hair growth. It can be seen. It's not common. It's not uncommon. Lots of women
Okay.
can have, okay, such hair growth. But the point is, the ors, okay, women want to be look like woman. That's nature,
Mm. Yeah.
okay. If she want to look like male, then that is the controversy, okay. So that is socially, psychologically, as well as in family, it is not emotionally stable condition. Okay, uh, we expect woman to look like woman, and she also expect herself that in that category. And when something is abnormal, then it is also frustrating for her, and that will follow her lifestyle will be disrupted, and her social life will be abnormal. So such client should have what need some sort of checkup and treatment. By the way, there are lots of women who are shaving their beard at home in bathroom
Mm.
because of this social disfiguring appearance. Okay, so not only shaving is not is one treatment, yes, but as we know, shaving is temporary. So
Yeah.
to
Yeah.
avoid it
Okay.
grows permanently, there are other ways. Other ways. It can be electrophoresis, it can be hormonal suppression, or it can be other. Okay.
Okay. So the very last question is someone is asking that you earlier mentioned that PCOS is genetic, there is an age factor, and there is an environmental factor in it. So she's wondering how does the environment contribute to someone having PCOS?
Mm-hmm. Uh,
Mm.
First, let me come to age factor. We say age factor, uh, not only the young, uh, but also in elderly can have this PCOS manifestation. Even without PCOS, elder women can have hirsutism, hair growth, elderly women, after menopause for that matter. Why? Even after menopause, ovarian production of testosterone, androgen hormone is continuous, even though there is no production of what? Estrogen hormone. So in those elderly women, you can have what? Hirsutism. So the second point that has been raised is the effect of environment uh, for PCOS. So always in science, something cannot happen out of a blue. Okay, even though there is a major factor, there are what minor, very important substrates that will make something to happen. Okay, uh, for example, with simple example, we are having this discussion uh, by lots of logistical participation, including the IT person, participation of me and Judy, and you should be also the audience should be here. There should be electric power, not only electric power, there should be internet. Okay, so without this communication, even we should have what desktop or mobile to have these things ready. So even though the primary is the genetic issue, the dietary issue, and the physical habitus, even living in hotter environment, even though it is less strong, it is a risk factor. Okay, so this all increases. How hot environment? Because in hot environment the diet is somewhat different than what we eat in cold environment. Okay, and the food that we are taking is also higher, so this will change what our body habitus. We are high likely to be obese, or when we say environment, the diet that is in our environment. And especially currently or by this time, the food that we are eating is highly processed. This highly processed food, or this uh, highly processed food in the market, in the supermarket, are labeled as unhealthy. So when we say unhealthy, there risk to facilitate the manifestation of what? The manifestation of PCOS events. That's why diet is also a treatment. Okay, one of the treatment for diet of PCOS manifestation is diet modification. Okay, so always environment is very strong factor in every aspect of life, not only in this aspect of life, in its aspect of health. Okay, environment is strong. It plays a strong role in everything.
That's so true. That's so true. And I hope the person that asked the question really got their answers right there, because with the clear explanation you've given, I believe they have perfectly understood how the environment contributes to not only their fertility but their health in general. Thank you so much, Dr. Ayaleo, for that elaborate explanation on everything fertility. You are the right expert to talk about these things, and I believe as we continue to have these discussions, people will begin to understand why they need to pay attention to their bodies and why they need to pay attention to fertility and talk about these hidden conversations that no one wants to share in public. If any of you listening or watching would love to reach out to us, you can reach out to Fertility Point. Their website is www.fertilitypoint.co.ke for Kenya, and Mom's Cover is www.momscover.com. So for any other information, any additional questions, feel free to reach out. We are on LinkedIn, both Judith Akite on LinkedIn, and there's Fertility Point Kenya on LinkedIn. So any questions that you feel were not answered because of time, or you are scared to ask in public, you can kindly DM me or reach out to Fertility Point for further discussions on this. And then we can see how to support you on your journey to becoming a parent. This is what we are all about. Thank you so much. Over to you, Dr. Ayaleo. You can give us your parting shots and then we can have this close.
Oh, you have already said everything. What I can say is that it's a very important and very interesting discussion, and I really thank you, the psychological consultant and the counselor. I appreciate. Huh? And our audience will find lots of important things from you, and also I appreciate the IT individuals who are organizing these things to happen. I really thank you. I really appreciate. Okay, thank you very much.
Maybe the other one thing that I should add is these webinars will be running every second Friday of the month. It's going to be monthly, so stay tuned and keep learning and seek for support. Otherwise, it's a
Oh,
bye-bye from me.